Distinguished guests, colleagues, ladies and gentlemen, welcome to the regional workshop on accelerating AMR action through antimicrobial stewardship in the Americas. This is the first of 6 regional workshops that will culminate in a global workshop on the 30th of November next week. My name is Sabiha Isaac. I am chairperson of the Global Respiratory Infection Partnership, sponsored by an unrestricted educational grant by Reckitt in the United Kingdom. Reckitt has sponsored this pharmacy-led stewardship initiative in partnership with the International Pharmacy Federation since 2019. It is my pleasure to introduce the AMR advocates for the region who will be facilitating the workshop. The first is Doug Burgoyne. He is an adjunct associate professor at the University of Utah College of Pharmacy. His previous roles at Moderators saw Dr. Burgoyne manage clinical pharmacy functions and programs alongside disease management for self-funded employers. Dr. Burgoyne is also a member of the Global Respiratory Infection Partnership, or GRIP, past president of the Academy of Managed Care Pharmacy, and a founding member of Utah Aware, an antibiotic resistance education program for the state of Utah. Eduardo Savio is the president of the Pharmaceutical Forum of the Americas and served as the chair of the FIP Policy Committee on Antimicrobial Resistance in 2018. He's also the head of the Nuclear Pharmacy Research and Development, specifically in the pharmaceutical chemistry and biomedical areas at the Uruguayan Center of Molecular Imaging, and he's also a member of the directive board of this institution. Dr. Savio has served as editor of the Uruguayan Journal of Pharmacy and Chemistry for 30 years. Over to you, Doug and Eduardo.
Thank you, Sabia. It's a pleasure to be with each of you today. We welcome you and thank you for joining us for this great panel discussion. As Sabia mentioned, my name is Doug Burgoyne, and I will take you through our agenda and our meeting objectives for today. So on our next slide, we can see our agenda. First, we'll have just a few minutes led by Eduardo talking about the roadmap progress. As you recall from the FIP GRIP meeting last year, we created a roadmap for AMR progress, and Eduardo will walk us through that. Then we'll have our panel discussion. This is what you all came to hear. We have 4 wonderful presenters from different parts of the Americas who will share with us case studies about antibiotic resistance programs and stewardship within their areas of practice. And at the end, and I'll make a further introduction later, but remember that at the end, we need to decide which one of these 4 presenters will present representing the Americas at the November 30th meeting that Sabia had mentioned. And then we'll have some discussion, and then we'll wrap up. Our meeting objectives for today's meeting are pretty simple. Number 1, to highlight the leadership role of pharmacists in antimicrobial stewardship. Pharmacists play a tremendously important role, as you are aware. Second is to drive behavior change and commitment to AMR initiatives through a 3-year AMR roadmap. And number 3, to share learnings and best practice from across the region to inform future initiatives in the prevention of AMR. I think we'll meet all of these objectives as we go through our program today, and can't wait to hear from our panelists. But first, let's review the progress that we've made on our roadmap so far. Eduardo?
Thank you, Doug. Thank you very much, Sabiha, for your kind introductions, and welcome everybody again. Well, last year during FIP Virtual Congress, we arrived to these 3 top initiatives that are introduction of training at undergraduate level through the interaction with Executive Board of the Pan-American Conference Pharmaceutical Education, which is sponsored by PAHO in the region. to promote patient counseling in community pharmacies with emphasizing non-antibiotic symptoms relief for viral infections, and to promote antibiotics dispensing under medical prescriptions and support policy enforcement requiring prescriptions for antibiotics. Considering these three initiatives, we identify key actions area in terms of education, policy, and public health. We also agree the strategic objectives that are included in the Global Action Plan of AMR. And finally, we suggested certain initiatives to be developed along 2021 and also for next year. And these three different initiatives that you can see with the letter A, B, C, D, E, and F, it takes into consideration very important objectives that have been included in the Global Action Plan. One is in the area of improving awareness of understanding of antimicrobial resistance through effective communication, education, and training. Another one that we will consider is in terms of reducing the incidence of infection through effective sanitization, hygiene, and infectious prevention measures. And the third one is to optimize the use of antimicrobial medicines. In next slide, Jordan, please. Next slide, Jordan. Thank you. The previous one, okay. Here we can consider which is the progress that has been taken along this year on relation to one of the initiatives, that is introduction at training at the undergraduate level through the Pan American Conference of Pharmaceutical Educations. This conference was carried out in September of this year. The hosting country was Argentina through an organization that is, this name is FIP, that gathers all the schools of pharmacy in this country. And this issue has been considered, but we are going also to establish, because we have a relationship from the Pharmaceutical Forums of the Americas with the executive board of the conference, that this important issue to be introduced in next conference to be celebrated in 2023 in Panama. The second line, instead of participation of National Pharmacists Organization during this week, we have received through national organizations different proposals, and between all the proposals, the best examples has been selected and are the 4 cases that will be shared to date. And so different initiatives we will keep in this row for next year in terms of considering what our national organizations propose and are developing in this moment. And finally, to support the PROA approach in hospital pharmacy, a very important agreement has been done between the Pharmaceutical Forum of the Americas and the Society of Infectious Disease Pharmacists of USA in order to train 12 pharmacists from 3 different countries, Argentina, Colombia, Costa Rica, and this training will be implemented. And one of the most important things is that at the final of these trainings, 12 different projects directed by tutors will be ready. We are also considering to have a publication with these projects in Spanish, English, and Portuguese. Next, please. So now, Doug, can you please introduce our speakers of today? Thank you.
Outstanding. Thank you, Eduardo. It's exciting to see the progress that has been made on the roadmap so far. All of the activity that happened in 2021, despite our technological issues and travel issues, and then the progress that will be made in 2022. One of the things that we're tremendously excited about is using pharmacists as influencers even in social media campaigns where pharmacist chat rooms are established, or pharmacist influencers are sharing ideas around antimicrobial resistance and antibiotic stewardship with their colleagues. We feel like this will be one of the ways that we can have an impact locally on antibiotic stewardship programs in 2022 and 2023 as well. So with that, we have 4 panelists today from different parts of the Americas. First, we'll have Jose Pablo from Costa Rica, representing Central Americas. Then we'll hear from NATASHA, who hails from the Chicago area, followed by SONIA, representing South America and Argentina, and then Laurel from Wisconsin in the US. As we turn the time to each of our panelists, we will ask each of you to give a very brief introduction prior to beginning your presentation, and then share with us the slides that you have prepared. And then we'll have our panel discussion after each of our presenters has been given an opportunity to teach us. So with that, we'll move to the next slide, and Jose Pablo Diaz-Madrid, if you would introduce yourself and then begin. Thank you.
Yes, thank you. As you heard, my name is Jose Pablo Diaz. I work as a clinical pharmacist in Clínica Bíblica Hospital in San Jose, Costa Rica. I also work as a professor of pharmacology in the University of Costa Rica and another university here in Costa Rica called UCMed. And I'm also an international consultant for the Pan American Health Organization on topics related to antimicrobial stewardship programs here in Latin America. And my project is, so we measured the impact of a 5-year intervention of our antimicrobial stewardship program on the optimal antibiotic prophylaxis selection in surgery. So as a background, my hospital is a private hospital without restrictions on antibiotic prescriptions. So that means that, for example, in this case of surgery, if a physician, for example, wants to use meropenem as a prophylactic agent for a C-section, he is in the capacity of doing that. So it's kind of hard to work in that kind of environment. So in this before this project, we did an audit. So we realized that we have a high percentage of inappropriate prescription of surgical prophylaxis. And our biggest issue was that they were using a lot of ceftriaxone as the prophylactic agent of choice. And as we know, this is a 3rd generation cephalosporin, so it's not like the best agent. So in this project, we wanted to establish what is the impact of our antimicrobial stewardship program after 5 years of working with the physicians. So we did a retrospective observational study where we compared the selection, duration, antibiotic consumption, bacterial resistant profiles, and patient safety outcomes. So we did this for 2 periods, one before the implementation of our antimicrobial stewardship program and one after 5 years of work. And these are the results. So if you can see on the optimal selection, we start with 21%, and then we got to an 80% of optimal selection. We still have some work to do, but we saw a really big increase of the comply with the guidelines, and I will talk about our interventions in the next slide. Our optimal duration also increased in 9%. And as you can see, we decrease the consumption of ceftriaxone. This is the data for all the consumption in the hospital. And we increase the consumption of cefazolin in a very big percentage. Also related to this, we have some interesting decrease on antimicrobial resistance trends in some organisms, but this one was significant. We decreased the ESBL detection on E. coli with an 11% decrease. So this is very important. Probably it's not just related to this work, but this shows that we are getting some good results with our interventions. And another important thing is that we didn't have any more surgical site infections, and we didn't manage to see any adverse drug reactions related to this change. And next slide, please. So if we see our consumption trends in these 5 years, this is what happened before the implementation of our antimicrobial stewardship program and how we were right before the pandemic. So if you can see, we start getting increases in cefazolin and decreases of ceftriaxone. And this is basically after we did a clinical guideline. We do a lot of education of our physicians, and then we start working by specialties. So we start, for example, with gynecologists, then orthopedics, anesthesiologists, and even with internal medicine to talk about the project, to talk about why they were using ceftriaxone and not cefazolin, and the benefits of using cefazolin. And it was hard. It depends on the groups. They are very different groups of people, but we managed to convince a lot of them. But as I told you before, we still have some work to do in this topic with some of the physicians, but we're still working on that. Next slide, please. And to finish this, I think this project is very important because this is not like something that is not happening around all Latin America. For example, in this project, this is an article that is going to be published in a couple of weeks, probably. They did a point prevalence survey of antibiotic use. And if you see in 5 countries of Latin America, they saw that 11.1% of the prescriptions of antibiotics were for surgical prophylaxis, and the adherence to guidelines were only 54.3% for prophylaxis. And if you see this graphic, a lot of the use of antimicrobials is related to the WATCH classification from the WHO antibiotic use classification. So a lot of this yellow is 3rd generation cephalosporins, the same from my hospital. So I think this experience could be replicated in other countries or hospitals in Latin America. And I think we demonstrate that this could be done and that we have a good impact with our project. And that's it. Thank you.
Thank you very much, Jose Pablo. So now is the next turn. Please, would you like to introduce yourself? Thank you very much.
Yes, absolutely. Good day, everyone. I don't want to say good morning. It's morning here in Chicago, but it's multiple time zones here. So my name is NATASHA PETIT. I'm an infectious disease pharmacist here at the University of Chicago. We're a major academic medical center in a South Side neighborhood in Chicago, Illinois. And I'm here to talk with you this morning or today about one particular intervention that our stewardship program has implemented within the past year. Actually, February of this year is when we rolled out a new process here where we are requiring antimicrobial approvals for teams to continue vancomycin beyond a 72-hour duration of time. So essentially, we have a restriction process or approval process that is 100% pharmacist driven. And this is through a protocol that was vetted through our medical center committees as well as leadership. So we do have physician and leadership buy-in for this intervention. What we basically require is the review of the indication for vancomycin to continue once the patient has received 72 hours or more of vancomycin. This requires documentation in the medical record of the review occurring should it be deemed appropriate or necessary to continue the vancomycin beyond this time frame. So just very quickly, the major impact factor that we're looking at is overall impact on vancomycin utilization. And we track our vancomycin utilization here at University of Chicago according to days of therapy per 1,000 patient days. So already 8 months following the implementation of this intervention, we've observed an overall 15.5% reduction in vancomycin utilization. Next slide, please. I wanted to take a moment to just tell you the background for why we decided to focus on this intervention and how we're monitoring compliance, and then go through a few lessons learned that I think might help with being able to implement this really, I think, at any medical center. So here we chose to focus on vancomycin duration simply because we did some benchmarking data with other medical centers in the United States that have similar patient populations to us. So for example, trying to match medical centers that have a fairly large hematology oncology patient population as well as solid organ transplant. And we see that there's a fair, in comparison with some of these other medical centers, we are a high consumer of vancomycin when we look at our anti-MRSA antibiotic utilization. And you can also see that we spend a fair amount on vancomycin. It is basically of all of our antimicrobial expenditures, we do spend the most on our use of vancomycin here. So it led us down the path of wanting to evaluate what's happening with our vancomycin utilization. And while it seemed to be the case that vancomycin was being initiated appropriately according to our pathways and guidelines that we have in place, we were noticing that empiric durations of therapy seemed to be a focal point or something that we needed to work on. Next slide, please. There's a lot going on this slide, but this is just to show you what the process is for evaluating the vancomycin orders. So obviously, when we have a situation where vancomycin is clearly indicated to continue at that 72-hour mark, we simply have our clinical pharmacists place a note in the medical record to document that it was reviewed at 72 hours and provide an indication for why it was appropriate to continue vancomycin. In the event that it is clear that vancomycin is not indicated, then we ask that the pharmacist reach out to the primary care provider to discuss the indication, to recommend discontinuation. But we do have a backup in place for them to reach out to specifically our antimicrobial stewardship program if there ends up being disagreement between the primary provider and the team pharmacist. So if there may need to be additional review, then antimicrobial stewardship can be contacted and review the case. Next slide, please. So in order to, I think, maintain a good amount of motivation with our clinical pharmacists that are really the ones that are boots on the ground, that are implementing the intervention, we are keeping track of compliance with this process in which the review needs to take place. And if vancomycin is continued, that a note is placed in the medical record. We just looked at a 4-month snapshot here, and we can see that overall 92% of the time when a patient is receiving vancomycin for at least 72 or more hours, there is a documented note in the medical record that was placed. So we like to give these metrics and show them to our clinical pharmacy team so that they're aware of the fact that they're doing a good job, but also that we're making sure that this process is continuing to be implemented appropriately. Next slide, please. And here is just a nice graphical representation of the outcome that we already shared with you in terms of the overall reduction in our vancomycin utilization. You can see the red bar is indicative of just overall use. So all of our adult inpatients that receive vancomycin, you can see we've reduced utilization by about 15.5%. We also looked at what it's looking like with our ICUs. As you can see, a slightly larger impact when we look at the impact on the duration of empiric vancomycin or vancomycin utilization overall in our intensive care units. Next slide, please. And so with that, in terms of, do I think that this can be implemented at any medical center? I really think so. I think obviously it's going to depend on what resources you have available in terms of who is actually implementing this. But I think placing a restrictor on continuing vancomycin beyond 72 hours, especially if you are at a hospital where you see prolonged durations of therapy of vancomycin, especially when started empirically, that this is something that you can target easily by requiring that there is approval required to continue it beyond a certain time point. I think in terms of our tips for success, I think it's been really helpful that we have placed the primary responsibility onto the assigned or rounding clinical pharmacist. Having a backup approval mechanism is very important, though, because obviously if we're going to ask our clinical pharmacist to implement this, we need to be available for if there are times where there is disagreement between what the clinical pharmacist would like to recommend and what the medical provider is able to do or willing to do. Very helpful to report performance as well as impact metrics to those individuals that are carrying out this intervention on a daily basis. I think it maintains motivation to continue the process. And last, I think the step of requiring documentation in the medical record is important because it does help to maintain visibility of the intervention. And I think that's all I'm going to share with you today on this, but I'm looking forward to the discussions later.
Thank you very much, Natasha. It's a pleasure. Thank you. Next speaker is Sonia Umbia on behalf of Isabel Tenchado from the College of Pharmacists from the Córdoba, Argentine. Can you please introduce yourself, Sonia? Thank you very much for joining today.
Okay, I have a problem with my camera. Well, I had to change the device. And can you hear me?
Yes,
okay?
Perfect. Okay, go ahead. Thank you.
Well, my name is Sonia Uema. I'm the director of the Information Center at the University of Córdoba, and belonging to the Faculty of Chemical Sciences. But I'm collaborating with Córdoba Pharmacists Association, and in this case with the Community Pharmacist Committee, who was the committee. They were who developed this project of good dispensing practices for antibiotics, most in demand in community pharmacies. And well, this is a project which aim was to develop a good dispensing practices program for antibiotics, most in demand in community pharmacies in the province of Córdoba, to improve, to diminish the antibiotic resistance and to improve the patient knowledge. How to tell it in a different way is to say that this was to empower the patients with knowledge, because they need to know why they need a prescription for antibiotics and how to use them properly. So this is 3, 4, 5 steps. I'm not sure how to define it, because it was designed. The first step was to design the standard operating procedures on good dispensing practices for antibiotics, and then there was an educational activity, a training program for community pharmacists, and that was the first and the first step of this project, because the implementation of these procedures was based on the training, and then the recruiting of pharmacists and patients, and data collection. This was based on the educator role of pharmacists, and drug information for pharmacists and for patients about antibiotics, and referral if it was required. And finally, the pharmacists used surveys for measuring both the adherence to HPV treatment and the patient satisfaction with this dispensing process with online questionnaires. And well, this is the summary slide. So I can say that the procedure on good dispensing practices for antibiotic most in demand in community pharmacies was developed and validated and complemented by a training program, drug information sheets, and online tools to register and assess the professional activities. What are the key learnings here? That the experience can be adapted to other environments and settings because it was based on the pharmacist themselves. I think that it was the key of this project, because it was the committee of community pharmacists who designed and both the procedures and the training program to be carried out by pharmacists. And it was to enhance the educational role and integration into health team by referring the patients. And other thing that's important, that patient satisfaction assessment was high for this experience. And in the next slides, we can see a few numbers and the results of this project. These are the most in demand antibiotics. You can see penicillin, amoxicillin, clavulanate, azithromycin, cephalexin, ciprofloxacin, sulfamethoxazole, and trimethoprim, and well, there were a few others, but these are the most in demand in community pharmacies, and it was discussed before the project was carried out. You can see there were two different procedures depending on the prescription, or if it was self-prescription. A total of 278 pharmacists were trained, and about 200 were recruited for the project. And you have the interventions, pharmaceutical interventions, and self-prescription cases that were based on referral to physician or dentist, proper use of antibiotics information with the information sheets and the counseling, and minor ailments indications. In the prescription group, the Morisky Green test was administered, and there was a 57% of adherence. It was, the expectations were higher, but well, that was the results obtained. Dispensing process, patient satisfaction was high, from a scale ranging from 1 to 5, it was 4.2. So I can say also that the opportunities here were the strategic alliances with universities, especially with pharmacy career, the professional associations. This also another strategic alliance, because antibiotic use is a problem that all health professionals are worried. So on a professional organization, national or international level, this project was financed by the Regional Pharmaceutical Forum of the Americas. And I think that the strength of this project was that the initiatives were by the same colleagues. This was the committee has very enthusiastic colleagues to discuss, to propose, and make things done. And the integration to primary care healthcare teams. This is, I think that's all.
Excellent, Sonia. Thank you very much. Outstanding. And we'll move to our next slide and our last panelist.
Hello, everyone. My name is Laurel Lagenza, and I am a pharmacist at the University of Wisconsin-Madison. And today I'm really excited to talk to you about our research with the AMR tracker. And this project started early in my Global Health Fellowship, where I noticed as a pharmacy student, as well as a pharmacist, that the antibiogram, which is a table of antibiotic susceptibility or resistance, was really underutilized. It often might be used on an infectious disease rotation as a teaching point, but I wasn't seeing my colleagues, physicians, and other pharmacists using this resource that's rich with local data when making antibiotic treatment decisions. So for example, a patient might come in with an infection and they're able to go home quite soon, but the laboratory result of that susceptibility won't be back for sometimes up to a couple days. So this tool is really for the point of care when you don't know when you're going to get the laboratory back. So this is empiric treatment decisions. So the objective here is to provide a resource that would improve the translation of antibiogram data into practice. And I was inspired by weather maps. When you see a weather map, if you can imagine a storm or a hurricane, you have an immediate reaction. You know where it's raining, where the probability of rain is, and really you have a rich understanding of all of this data that could also be communicated as the probability of rain in a city. So we tested this idea by collecting antibiograms from across our state of Wisconsin. And then we collaborated with some geographers on campus to make a geographic spatial interpolation of that data. And this created a proof of concept. And also we built an interactive tool to look at this data and engage with the data. And I'll show you what our results look like. Next slide, please. So what you can see here in the lower right, you can see where Wisconsin is in the northern US. And when we looked at these antibiotics of interest, what we notice is there's a unique pattern in antibiotic resistance by region, as well as by antibiotic. And some trends that I see in these maps, knowing the state well, is that there is reduced susceptibility towards urban centers, but also in valleys, which are high agricultural areas. So then we looked at how might we use this tool in practice. Next slide, please. And we created this prototype that would allow a provider to select a location, a suspected pathogen and site of infection, and then the tool will update with a list of antibiotics in the order of their susceptibilities. And of course, this isn't a final decision, but it's one more piece of data to optimize the empiric antibiotic chosen. And another impact of this project was that this mapping technique is highly engaging. So we received phone calls from our Wisconsin newspapers, public radio, as well as other news outlets that wanted to hear about this project. So we raised awareness not only among providers about the differences in antibiotic resistance in our state, but also at a public level. Thank you.
Thank you very much, Laurel. You have wonderful presentation adjusted to the time. We are almost 40 minutes since we have started. Thank you very much. So now it's time for discussion. I have one question from Jose de Grossi. He's from Argentina. This is a question for Sonia. Sonia Wema. The question is the percentage of antibiotic without prescription were detected prior or during the program. Is there a comparison of non-prescribed dispensation before and during the program? Can you please, Sonia, address this question? Thank you.
Okay. Was about the without prescription. This was during the project, and one of the slides I.
The question is if you have measured before starting the project.
No, there was no data before the project. Only one survey, but it was general for about antibiotic use, and not especially focalized on this aspect. So it can be compared.
Okay, thank you.
There was another thing there. I don't remember.
No. The question was the comparison before the project has been started and during the project developing.
Yes, no. This was during the project. These are the results of this project.
Okay, yes. Thank you. I think I have another question, but this is for Natasha. That what happens when 22 hours expires during a weekend? What happens during a weekend once you receive this kind of prescriptions? How you manage?
That's a great question. So actually, we still implement the same process, whether it's a Saturday or Sunday or during the week, because we do actually have pharmacist coverage of our clinical areas on weekends. It's a little bit more distributed that one pharmacist is covering more patients during that time frame, but still the way that our medical center is set up, every patient that is receiving vancomycin treatment is being reviewed on a daily basis by a pharmacist. And so in that review, whether it's to carry out therapeutic drug monitoring, we're also having them evaluate the indication. So it still occurs. They still address stopping vancomycin if it's not appropriate to continue. And we do actually have antimicrobial stewardship available on weekends as well for that backup should they need our support in pursuing discontinuation of vancomycin.
Thank you, Natasha, very much. I don't have more questions in the moment. I would like to ask Legend if this kind of surveillance is going to be extended and sustained in the future in your area. Can you please go a bit further?
So this research is ongoing, and what we're currently working on is redesigning the tool so it is most provider relevant. So the current model is highly engaging, but it would take a lot of time to work with. So now we are redesigning the data presentations and working with providers so it's best fit to what they need to see. And I'm also collecting data at the patient level, not just the provider level.
Excellent.
So the project is ongoing, and I am looking for collaborators beyond Wisconsin and expanding this project.
Thank you. And the final question for Jose Pablo. You have mentioned, Jose Pablo, that this experience has been shared by 5 different countries like Mexico, please help me, Cuba, Colombia, I think Paraguay, and Costa Rica. That the methodology you think it would be valuable for other hospitals. Is any initiative involving a further group of hospitals being considered?
For the implementation of this kind of project?
Yes.
Well, this is a basic a very basic, and if you check the recommendations for working on the initial steps of antimicrobial stewardship programs, probably surgical prophylaxis is one of the first things to do because it's very easy. So I don't know if they have anything implemented right now, but probably something that we, for example, from the Pan American Health Organization, we are asking them to try to implement this kind of projects, because it's very easy, and it's like, you have guidelines, and you have medical and a lot of evidence that this is the best way to work. So with guidelines and with people checking this, probably you can change the prescription patterns of the physicians. But even with all the evidence, sometimes physicians don't want to change the prescription. So it's a battle every day, but I think it's very possible to implement this in every hospital in Latin America.
Thank you, Jose Pablo. Can you take the floor, Doug, please, to go on with the poll?
Absolutely. Thank you, Eduardo. And thanks to each of our panelists. I loved hearing about the success of pharmacist-driven antibiotic stewardship programs within your areas. I think, Laurel, your weather map was pretty cool and a great model. Jose Pablo, I appreciated how you were able to switch from an inappropriate antibiotic to a more appropriate antibiotic and gain physician buy-in. And Sonia, I loved that this is a community pharmacy activity. That's really impressive. And NATASHA, the vancomycin, I think that the review by a pharmacist and chart notes into a physician have a significant impact, and you're showing that as well. So thanks to each of our panelists. Now we'll move on we'll bring our slides back up, Jordan, if we can. And as you recall, we said that we were going to select one of these one of our panelists to present at a global meeting on November 30th. That will be at 11 a.m. Central European time. So on the left side of the screen, you can see our 4 programs. Jose Pablo's Impact 5-Year Intervention of an Antimicrobial Stewardship Program on the Optimal Antibiotic Prophylaxis Selection in Surgery. Then we had NATASHA's vancomycin after 72 hours with approval. Number 3 was Sonia, who presented on good dispensing practices for antibiotics in community pharmacies. And then number 4 was Laurel with the AMR tracker. So we have 4 questions for all of our participants today. We will ask each of you to participate in the polls. So let's launch the poll, please. Our first poll, please. And here it is. Which initiative are you most likely to implement in your own country? Case study 1, 2, 3, or 4. Please take a moment to vote. I think this is interesting to think about. We have representatives from all over the globe and not just the Americas. So very exciting. And here are our results. 58% of folks saying that case study number 3 or Sonia's good dispensing practices for antibiotics in demand would be most likely to be implemented in your country. Thank you very much. That's very, very interesting. Okay, let's move on to our second poll. Please take a moment to respond. Which initiative could be implemented the quickest in your country? So which initiative could you most quickly implement? Case study 1. The second bullet should say case study 2. That is not Chicagoland voting. We are just 1 vote per case, please. So case 1, case 2, case study 3, or case study 4. And here are the results as well. So for the most quick implementation in your country, case study number 3, good dispensing practices in the community pharmacy. Excellent. And our final question, which initiative do you think would have the biggest impact on your country? So if we think about each of the 4 programs that have been presented, which of these 4 do you think would have the most impact in the place where you live? Again, case studies 1, 2, 3, or 4. Please take a moment to vote. I think this is the exciting part of the presentation, to know what we can do locally. And again, case study number 3 with Sonia's presentation on community pharmacy action. Thank you all very, very much. This has been a wonderful presentation of different types of antibiotic stewardship programs, whether in the hospital or in the community setting. We thank you all for your participation in the voting. Let's go to our next slide. Now, before we wrap up in our next steps, we thank each of our panelists, NATASHA, Jose Pablo, Laurel, and Sonia, for giving us some great education on antimicrobial resistance and stewardship programs within your communities and areas. I loved hearing what you had to say, and we'll be thinking about your programs as we go into community practice and hospital practice in my own community, and how I can have an impact. So we'll ask each of our attendees, think about all 4 of these programs and how you can implement them locally. All of these contribute to appropriate antibiotic stewardship and were great examples. So Sonia, we will ask you to prepare for our upcoming global event on November 30th at 11 a.m. Central European Time, where you will present the Americas case study representing all of us at the global meeting that Sabia mentioned when we opened. So ideas voted as the most, or Sonia's, will be showcased. And the question at that meeting is, are pharmacists protagonists in the fight against antibiotic resistance? Well, I think that we could make the case that in the Americas, pharmacists are protagonists in the fight against antibiotic resistance. So thanks to each of you, and thanks to you, Sonia, for representing us next week at the next meeting. Outstanding job. As you can see in the chat, we have a registration link. Please take a moment, if you have not already, and register for that program on the 30th. It will be fascinating to see what types of programs are coming out of pharmacy-led resistance and stewardship programs in different parts of the globe. So the FIP Commission on AMR, set up by the FIP Bureau in 2020, will monitor the progress on AMS roadmaps annually, and will continue to stimulate the global community of pharmacists to be active agents in minimizing antimicrobial resistance. This program has been sponsored by the FIP AMR Commission, as well as GRIP, the Global Respiratory Infection Partnership, with support also from Reckitt. We certainly appreciate the folks at Reckitt for supporting this type of program and appropriate antibiotic use throughout the globe. With that, I will say thank you, and I'll ask Eduardo also if you have any wrap-up comments or a final word to our panelists and attendees.
Yes, thank you, Doug. It has been a pleasure to perform as co-moderator of this webinar with you. Thank you to everybody to participate here, and I'm very glad for the 4 cases that have been shared today. Thank you, Natasha, Laurel, Jose Pablo, and Sonia. And for me, as president of the Pharmaceutical Forum of the Americas, that we have sponsored this project in Argentina, I feel very proud that it has been voted to that's the initiative that could be most quickly and with most impact, and that will represent on 13 November the region of the Americas. So congratulations, Isabel Tenchado, who is the leader of this group, and this alliance between the university and the professions, that is a key alliance to move these things in the future. So congratulations, the College of Pharmacists of Córdoba, for developing this initiative. Thank you very much, everybody, for being here today.
Have a wonderful day. Thank you.